Okay, this is our standard disclaimer slide. Okay, and these are the learning objectives for today's webinar. Today's webinar will provide an overview of steps necessary to create a successful coalition. We will share best practices for working collectively and provide 3 community examples that have incorporated best practices and met with successful results. The 3 examples we have one example from the National Implementation Initiative, and we have 2 very special guest speakers from the PICH initiative. Like the National Implementation Initiative, PICH is also a CDC-funded program. It builds on a body of knowledge developed through previously funded CDC programs and encourages collaboration with multi-sectoral coalitions to implement sustainable changes in communities where people live, learn, work, and play. PICH is a 3-year initiative that supports implementation of evidence-based strategies to improve the health of communities and reduce the prevalence of chronic disease. Okay, so let's start with community building basics. The overview for today is designed to be very brief, as most of you have already done some work with coalitions. I know a few of you are new to coalition building, and the national organizations that you are working with, American Heart Association, American Planning Association, and the National WIC Association, have provided, as part of your orientation, an introduction to coalition building basics as they relate to each of the national organizations. We'll start with the definition. A coalition is a group of individuals or organizations working together to achieve a common goal. Okay. This slide outlines 8 steps to building a successful coalition. These steps were adopted from a document put together by the Prevention Institute. Okay, step 1, discuss objectives and determine coalition needs. Groups need to be specific about what they're trying to achieve and the best approach to achieving those goals. Additionally, they need to ask some important questions like, what are the community's strengths and needs? Step 2, you need to find the right people. Some groups intentionally start small and then choose to expand. The size of the group is very important. Whereas a large group may have access to greater resources, a smaller group may be able to make decisions a little bit more faster. Outline detailed activities. Once the group has decided what the goals are, they need to outline the benefits of working together to avoid competition and develop some short-term objectives that will play to the group's strengths and interests. Step 4, convene your members. Once the coalition has had an opportunity to actually gather its group members, they need to work from time-specific prepared agendas, draft a mission statement, determine what the structure and membership of the coalition looks like, and be prepared for the fact that not everyone who's invited to join the coalition will actually become a member. Step 5 is budget and map your resources. There should be a lead organization, and the lead organization will often need to have some staff who are prepared to do some of the more detailed work. Additionally, a lot of coalitions are running on minimal budgets, so they need to consider that everyone's time is a valuable contribution. Step 6, create structure for a coalition. The coalition needs to ask some critical questions such as, how long does the coalition plan to exist? Where will they meet? What's the decision-making process going to look like? Who will create agendas? What are the rules for membership? And how will people engage? Step 7, plan for the coalition's vitality. This includes determining how the coalition is going to address the problem that it has identified, how it will share leadership, when and how it will recruit new members, and recognize contributions of individuals and other organizations at each step. Lastly, it's important to evaluate and use results from evaluation to improve the program or project that the coalition is working on. An evaluation can be simple, such as a feedback survey, or it can be more formal or structured, such as a pre and post test. specific subject knowledge. This next slide outlines a couple of best practices. This is not a comprehensive list, but it does have some pretty good ones for consideration. We will probably see examples in the 3 presentations from each of the example communities that follow. Align around common issues. Development of the group goals is a joint process. So instead of 1 or 2 individuals or organizations making all decisions, a group of people in a coalition should be deciding what the unifying issues are and what the goals of the coalition will be. Respect each group's self-interest. Each group has its own mission, vision, goals, and objectives outside of the coalition, and its reasons for being part of the coalition should align with each group's mission, but take into account that there should be a balance between the needs of the coalition and each of the organizations participating. You need to also respect that each group has its own internal process for making decisions and participating that will affect the coalition. And the coalition should also have some sort of outline for how they actually will make decisions. Another reminder to share credit and recognize contributions of those who are participating. In some cases, members will offer meeting space, others will provide funding, some will provide leadership or copying resources. There are a variety of ways that the stakeholders in a coalition will participate and be engaged. Like any relationship, a coalition is a relationship between the organizations, and there should be a give and take. Be prepared to compromise and support the goals and objectives of other members. The strategy that the coalition decides on should make sense to everyone who is participating. Some of the literature suggests that it's helpful to often have decision-making members of organizations participate, and that members of each of the organizations should be consistent from meeting to meeting for continuity. And then the last best practice that I have listed for today is formalizing the coalition. In other words, there should be some explicit agreement between the members of the coalition that help to outline what responsibilities and rights are, and also to help prevent conflicts. Okay, so this slide outlines some featured resources. We pulled some of the information from the prior slides, and also some recommended resources, including a few webinars that were previously done for the National Implementation Initiative. We encourage you to take advantage of these resources and others to help promote your coalition's work. Okay, I would like to welcome our first speaker, who is Aaron Mondada. Mr. Mondada is a community and regional planner for Agnew Beck Associates. He has a diverse background in city planning and public policy. He holds a Master's of Community and Regional Planning from Boise State University and a Bachelor's in Political Economy from the College of Idaho. Aaron has worked on a wide array of planning and policy-related projects, including a national study of creative placemaking through temporary developments, a Treasure Valley Arts and Economic Development Study, community food evaluations, housing studies, and neighborhood outreach and planning projects. Since joining Agnew Beck in 2015, he continued to serve communities through stakeholder engagement, policy analysis, best practice research, data analysis and survey design, and he's committed to making planning and policy useful for the end user and understands the outreach and engagement necessary to make this happen. In his spare time, he's an avid bike rider, gardener, reader, and is actively involved with local organizations, including the American Planning Association and Idaho Smart Growth. Aaron, welcome to today's webinar.
Hi everyone, thanks for having me. I'm excited to be here to share a little bit about the Idaho Plan for Health Coalition and our work with the Vista neighborhood, which is really a great example of a coalition between the city of Boise, the APHA, the APA, and a number of smaller local organizations who've all contributed to this process of defining the food environment for the Vista neighborhood. And I'll talk a little bit more about that project as we move forward. But I sort of want to talk a little bit about the Vista neighborhood, why it was selected for the CDC-funded grant, and sort of the process that led us to this point today. So if we could go to the next slide. So here's just a little image of the Vista neighborhood. Vista Avenue goes down the middle of the neighborhood, and this is a primary corridor in our community. It leads from the airport into downtown, and so this is a heavily trafficked area, but the neighborhood surrounding this corridor has a lot of indicators that we thought could lead to disparities in health, both physical activity as well as food and nutrition. And because the way the grant was oriented, we decided to look at primarily food and nutrition, which included things like access and food security to the residents of the Vista neighborhood. So this is just a little bit of an overview. It's about 4,500 housing units and roughly 10,000 people. So it's a relatively small geographic area, which is interesting because we were one of the smallest Plan for Health coalitions from the first cohort. I don't know the sizes of the second cohort quite as well, but we're working on a much different scale than some of the other coalitions who are looking at citywide initiatives. So our work is different, but very interesting and very useful for our community. If we could go to the next slide, I have a little bit of an overview of the demographics of the area to show you why we selected this neighborhood for our study area. You can see that the median household income is significantly lower for the Vista neighborhood than the rest of the city of Boise. We have far more rental units than homeowners in the area. The housing stock is aging, and it's a low median value. And what is maybe most shocking was that the two elementary schools within the neighborhood boundary have really high rates of free and reduced lunch program participation, which led us to believe that there might be some food security problems within the rest of the neighborhood, maybe addressing some of the very high refugee population within the area, area seniors, and just the residents in general. So this is sort of why we selected this area, in addition to something that I'll talk about a little bit later, which is our partnership with other programs and national studies that were taking place within this community as well. So we were really lucky, and we were able to build off of the energy in the excitement that it was already kind of building around the Vista neighborhood as an area for study and an area to test implementation strategies and actions that we're really hoping will have a big effect in improving the health of community residents. So this is just a little profile overview. This is a great place. I used to live there, but yeah, let's go to the next slide and talk about our work. So when we started this coalition back in April, we set out to conduct an in-depth analysis of the neighborhood's food environment, and we quickly realized that the data that was available in terms of health and community data in general just wasn't going to meet the needs of what we wanted to do within our assessment. And part of that was because of the small geographic area. Our local health organizations aren't keeping track of neighborhood level data to the level that we thought was necessary. And we needed to identify neighborhood-specific strategies in order to best affect the members of the community within the right context, and to help us identify actions that would be meaningful and not just try to copy and paste best practices from other areas. And this is an area like the neighborhood food investment study is an area that hasn't really seen much national attention, and so there hasn't been a very thorough model to follow. And well, like I mentioned earlier, there's a couple other initiatives taking place in the neighborhood, and so we had to sort of address maybe some of these community members have been over-surveyed and they've been talked to before. So just dealing with community fatigue in an area that they might not see results from some of the studies that have been going on, and so they might get frustrated. So working through these challenges, we really needed to build a coalition to make sure that our implementation strategies were correct and that we were looking at the right issues within the community. So yeah, let's go to the next slide. So I think what we as the Idaho Plan for Health Coalition did best was we were able to integrate with the existing initiatives that were taking place within our community. And these two major things are, first, the Energize Our Neighborhoods program, which was a city-run initiative with the intention to energize and enhance the livability of Boise's neighborhoods. And this sort of came out of a larger mapping process that looked at livability indicators, and Vista showed up as an area that could have a need for some serious improvements, and has since become an area that has received some meaningful implementation strategies. And this is the first neighborhood in this program that's hopefully going to expand out to other neighborhoods within the Boise community. And then also at the same time, right around when we received the funding from the CDC for our coalition, the Urban Land Institute announced that the Vista corridor was going to be one of their 4 national demonstration corridors, looking at the health of people living along the corridor, what kind of partnerships and collaboration would be needed to spur development, spur change for the positive indicators in our community, and what kind of changes really are necessary. So we were able to leverage these 2 initiatives, Energize and the Healthy Corridor Study, to sort of expand our limited amount of resources and to engage the community in a different way. So we didn't have to use all of our budget doing some of these initial scoping tasks that we were able to get out of Energize. And so we were really lucky in that sense that we had these 2 great partner organizations. And additionally, in light of the lack of community data, we weren't sure the best way to go about collecting neighborhood level health data, what kind of culture and food environment these people are living in, what are the dietary habits of the Vista residents, things along those lines. And so we were able to build a partnership with students from Mark Siemens' nursing class, which is an upper division nursing class, and Mark's a member of our coalition. So we formed a partnership with Boise State University and had the students actually do a lot of the groundwork. They did a neighborhood food study, which looked at the cost and availability of food within all the grocery stores within the area. And so we were able to find out if the Vista neighborhood residents were shopping in locations where the prices were maybe higher than other area grocery stores, and what kind of food was available, if it was meeting the needs of the cultural population, the refugee population. And they also were able to go and perform a door-to-door neighborhood food survey, which gave us a bunch of great information about the dietary habits, the living conditions, physical activity levels of these Vista neighborhood residents, which has really contributed to the success of our implementation strategies and the construction of the toolkit, which I'll talk about later. And just to highlight a couple other of the partnerships we were able to develop, we worked with the Boise Urban Garden School, which has now been brought under the umbrella of the city of Boise, to start some community garden initiatives and to really look at what it would take to make meaningful change within the community in terms of bringing more healthy produce and local produce to the community. We also worked with United Way. They helped us review our implementation strategies and our actions and gave us some great suggestions as to maybe ways to tailor our recommendations to the community. And we also were able to partner with our local Let's Move chapter, Let's Move Boise, and they gave us some great ideas, and we've been able to use some of their resources in our assessment process as well. So really successful coalition building activities going on here in Boise. Next slide. So a couple other success stories I wanted to quickly bring up. Looks like our photo got shifted a little bit. But we were able to access some local champions. Underneath the umbrella of the Energize Our Neighborhoods program, a Health and Community Services Board was created, and we've met with them throughout our year-long grant process, and they've been great actors to sort of take on some of the smaller challenges and implementation strategies we've recommended. They are in the process of currently looking at creating a community food council, which was one of our recommendations, and we were able to use their excitement and their resources to implement some strategies that we don't have the funding to do. And it's great to see these local neighborhood association presidents get really excited about some of the initiatives we proposed. One other success we had was we partnered with APA Idaho, which I guess we are that organization, more or less. But they sponsored gift card incentives for our survey respondents, and so we were able to give back gift cards to the local grocery store to hopefully get some healthy food into the hands of community residents. We've also started constructing a toolkit which will help other neighborhoods within Boise build neighborhood level data, particularly for public health and food assessment purposes, which we think is a really great initiative because it'll give us and other coalitions in the future, other partnerships, data that they need to look at what the context of their community is in terms of health and nutrition. And then really just looking at long-term project sustainability. We knew from the very beginning that since we only had $125,000 and a 1-year time frame, more or less, we had to start building these partnerships for sustainability if we wanted to see any of our programs come to light. So we're really hoping that the Energize program, as well as our local champions and our work with United Way and Let's Move, can help take some of these ideas into reality, and hopefully, 3 to 5 years from now, come back and see what kind of success we've had as a coalition and what kind of success in new metrics for evaluation we can look at moving forward. So that's really just the basic of our success stories. Next slide. The last thing I sort of wanted to talk about today was this toolkit for success, and we think this is what sets our coalition up for long-term sustainability and future successes, is taking the process that we've designed in terms of the food assessment and the evaluation, everything from the local data collection processes we used and some of the context-specific evaluations. And we've also offered tools to help future neighborhoods or communities look at their food environment. So one of these things, which you see below, is the food consumer spectrum, which we've hopefully set up in a way that will allow people to sort of monitor the progress of their coalition, with the goal of moving individuals from the red zone on the far left of the severely food insecure along the spectrum to healthy food consumers. And sort of with our toolkit, it shows what interventions might be targeted towards the low to moderately insecure group, or what interventions can be used to make sure that the healthy food consumers maintain their positive diets and their positive lifestyles. And so we're hoping that this process can be transitioned from this neighborhood, the Vista neighborhood, to other neighborhoods in Boise and communities within Idaho, and who knows, maybe even nationally. But this toolkit is kind of our final product that we're hoping to push out to not just the APA and the APHA, but to communities within our state and broader. So next slide. Yeah, that's the basis of our coalition. We're really excited, and we think we've done some really great groundwork, and it's going to be necessary to maintain these coalition partnerships we've built throughout this last year in order to see real successes within our community and meaningful changes to our residents' nutritional consumption. So thank you.
Okay, Aaron, thank you for sharing. If you have any questions for Aaron, you can type them into the question box, but we will come back to them at the end of the presentation. I'd like to introduce our second speaker, who is from the Boston Alliance for Community Health. And our speaker is David Aronstein. He's been the director for Boston Alliance for Community Health for the past 5 years. BACH is an alliance of neighborhood coalitions, hospitals, health centers, community-based organizations, and the Boston Public Health Commission, committed to health equity. In partnership with the Boston Public Health Commission, he led the MAP Community Health Needs Assessment process for the City of Boston. It engaged over 2,000 people between 2012 and 2014. He was a clinical social worker for the North Shore of Boston before joining the AIDS Action Committee of Massachusetts, and as a member of its original senior team in 1985. He's worked as a consultant to health and social service agencies in program development and strategic planning for a number of years before founding Stonewall Communities, which is a nonprofit organization whose mission is to develop opportunities for older members of the LGBT community. He's the co-founder of the LGBT Aging Project and has served on the boards of the Fenway Community Development Corporation and Community Research Initiative of New England. Mr. Aronstein is a graduate of Yale University and earned an MSW from Smith College School for Social Work. He currently lives in Jamaica Plains with his husband Stephen and their dog Marley. So David, welcome to today's webinar, and thanks for joining us.
Thank you, Cheryl. Thank you, and I wanted to start by saying that my colleague Ann McHugh, who is our major coalition partner, is ill today, so she's not able to participate today, so I'm going to do this just myself. Next slide, please. So let's get healthy Boston. We are a partnership to improve community health project, PICH. And I'd like to start by just saying that one of the formulas that I often use to think about change is that in order for change to happen, you have to have dissatisfaction, you have to have a shared vision, and you have to have an agreed upon process. And I think this applies to effective coalitions too. So the other thing I wanted to say is that the scale that we are operating on is very different from that of Boise. But I think some of the principles can still apply. So the partnership, the Boston Public Health Commission, BPHC, is the City of Boston Health Department, and they're the PICH grantee, the manager, and co-convener. The Boston Alliance for Community Health is a citywide health coalition, and we're the co-convener, and we manage the community engagement process for PICH. Next slide, please. The Boston Public Health Commission, they often start with their history that Paul Revere was the first director of the Board of Health of Boston, so they have a long history. Their mission is to protect, preserve, and promote the health and well-being of all Boston residents, particularly the most vulnerable. They have 1,100 employees, which includes the emergency medical technician program, and a $170 million budget. And the executive level offices have worked with BACH on policy and planning for many, many years. They've also managed 4 previous CDC chronic disease prevention projects and has experience assembling leadership teams based on each project's objectives. Their staff includes 12 people, and some of the staff have participated in the BACH planning process that Cheryl referred to at the start. Next slide, please. So the Boston Alliance for Community Health, or BACH, our mission statement is that we unite public, private, and not-for-profit partners in neighborhood-based data-driven health planning and improvement in order to influence policymaking, program development, service delivery, and resource allocations that protect, promote, and improve the health and well-being of all Boston residents. We've been around for about 20 years. We were founded in collaboration with the state health department, who created community health network areas around the state to drive health planning and improvement down to the local level. And we have very strong relationship with hospital community benefit processes. We've been known as a coalition of coalitions and allies. We're an umbrella organization for 10 neighborhood coalitions, hospitals, health centers, community organizations, and residents. As Cheryl mentioned, in 2012, we initiated the Mobilizing for Action Through Planning and Partnership health planning process, which included a close collaboration with the health department and involved a lot of people. We developed what is the citywide strategic health improvement plan. Next, please. So the structure of our alliance is different from the health department. We're housed in a local not-for-profit public health organization which serves as our fiscal sponsor. We have a steering committee that is made up of 20 members, 9 from neighborhood coalitions, The Conference of Boston Teaching Hospital has 2 seats. The Massachusetts League of Health Centers Boston Conference has 2 seats. We have 5 at-large seats, and the BPHC Executive Office and the Massachusetts Health Department, Public Health Department, has seats. Our staff consists of me and our community organizer. And now we have 3 staff because through this grant we were able to add a community engagement manager for this project. Next slide, please. So when this FOA came out, it called specifically for a health department to form a partnership with a community-based coalition that had done a health improvement planning process within the last 3 years. And I kind of looked around and thought, that's us, because nobody else had done this in Boston. And Ann McHugh, who is the principal investigator, she and I basically called each other immediately and said, we have to do this together. And part of it is we saw it as a sort of win-win scenario. So it's an opportunity for sustainability for the Health Commission, which around these initiatives, because they operate on grants, and while we also get grants, we also try to create community sustainability. It was an opportunity for them to build on our connections in the neighborhood through the coalitions and the organizations that are connected with us, as well as the hospitals and health centers. For us, it was an opportunity to fund neighborhood-based community engagement strategies, to incorporate elements of the Strategic Health Improvement Plan that we had worked on, and an opportunity to expand the BACH membership and involvement to new sectors. It has been and continues to be a collaborative process. In the grant planning phase, the Commission and some members of the BACH Steering Committee met 5 times. We added other representatives from other sectors so that we came up with an agreed upon set of goals that were consistent with what the CDC was asking for. It was a kind of give and take process, because for ours there are very specific CDC objectives, and our health improvement plan, while it has some specific objectives, also had some large goals around integration of clinical and prevention, as well as achieving racial and ethnic health equities, which are very broad. But it also developed principles for incorporating attention to social determinants of health within these more midstream objectives that the CDC was looking at. So in the grant implementation phase, we formed an oversight committee that has some members of the BACH Steering Committee, as well as other members, and Ann and I are on it. But it also includes a director of a community development corporation, the health and wellness director at the Boston Public Schools, the transportation department, a citywide faith-based organization, a public health policy expert, the Livable Streets Alliance. And we invited some other people, and some said yes and never showed, and others said no, they didn't want to participate. So not everybody says yes. And I'm the facilitator of that oversight committee. The one thing I wanted to say that's not on a slide is that our major way that we are implementing this is a combination of staff from the Health Commission, who are funded through this, as well as the one staff person that is funded for us. But then we've taken a healthy community approach to our work. So in addition to the staff, we recruited 10 specific community-based organizations, which range from community development corporations to a food and fitness coalition, health centers, a Latino organization, who in turn then recruited a total of 75 residents who are serving as healthy community champions to work in their neighborhoods on implementing the specific policy, systems, and environment change goals of this grant. Just to clarify, the things that we're working on are increasing the number of smoke-free housing units in multifamily developments, increasing access to affordable healthy beverages and food, increasing opportunities for safe and affordable bicycling, and implementing a Safe Routes to School initiative in 26 of the Boston Public School elementary and middle schools. These healthy community champions are amazing. They're comprised of women and men aged 15 to 70 who speak a total of 5 languages and are from 10 different neighborhoods. They've begun to be known as health advocates in their neighborhoods. We've developed a intensive training program for them, both around social determinants of health, health equity, some advocacy skills, as well as the specifics of the content areas. And they've been empowered. A number of the HCC groups have formed communities of practice where they share the lessons learned and help each other achieve their goals. They've reached out and engaged with city councilors and state senators and reps to gain support for these policy changes. And this is the first time for many of them that they've engaged with policymakers, which has increased their own confidence to make community change. So we have a grassroots and a grass tops approach. And one example of this is that we have a goal to decrease the consumption of sugar-sweetened beverages, SSBs. So we have engaged on the corporate level with 2 large pharmacy chains in the city, which have become kind of neighborhood food stores, the large chains. I'm sure you're familiar with them, CVS and Walgreens. And in an effort to get them to rearrange their merchandise and to promote and prominently display water for purchase. And simultaneously, the Healthy Community Champions are engaging their neighborhood store managers to enlist their support in doing educational events to promote healthy beverages and educate their neighbors about the sugar-sweetened beverages. So the next slide, please. So just some things that we wanted to highlight around coalition work. There are different organizational cultures of coalition members. So we have the Health Commission, who's, you know, incredibly dedicated to public health, but they're part of a municipal bureaucracy. And we are a community-based coalition, which have a lot fewer hurdles to get things done. And sometimes there's conflict about that. Also, this is a collaboration between professional staff and a lot of community residents who, again, you know, have very different cultures and ways of doing things. And I think for the health department, it's been a real learning experience in terms of effective ways to engage large numbers of community residents. As I mentioned, you need to pay attention to process while working on the outcomes. So having clear decision-making processes is important, but also very hard to do sometimes when there are processes within the bureaucracy that community members don't quite understand. We've been trying to balance the specific requirements of this grant with community goals and values. So with this group of empowered residents, they often want to go off and do other things, which we have gone back and forth about whether that's okay, and have agreed that they can as long as they're meeting their goals for the grant. And finally, leveraging strengths, relationships, and the capacity of partners beyond this specific project. From our perspective, we saw this as an opportunity to create this community-based resident core of educators, advocates around these community health issues that we hope to be able to sustain beyond the grant. So it was a capacity building effort for us. And for the Health Commission, they have access to a lot of different staff and expertise that has been brought to the grant, even though not necessarily covered by the grant. Next slide, please. And so I will stop there because I think my time is up. And here's our contact information, and I'm happy to talk to anybody who has specific questions. So I'll stop there. Thank you.
Okay, David, thank you for that great overview of work going on the PICH project in Boston. Okay. Our third speaker is from Partnership for a Healthy Lincoln. Dr. Bob Rauner has been working on population health projects across Nebraska since 2010. Previously, he worked for 15 years taking care of rural and low-income patients as a family physician, as well as teaching at a residency program the last 7 of those years. His primary day job is working on community health projects as director of Partnership for a Healthy Lincoln, but he also works on legislative and health policy issues through the Nebraska Medical Societies. He received his undergraduate degree in philosophy from Creighton University, a medical degree from the University of Nebraska Medical Center, and a Master of Public Health degree from Johns Hopkins. His wife Lisa is also a family physician, and together they have 3 daughters. Bob, welcome to today's webinar.
Thanks. Well, if you want to go ahead to the next slide. Like you mentioned earlier, we're a PICH grantee just like David, and have a lot of some similar challenges actually. So if you want to click to the next thing, this is something I use in graduate school, and I still like this model. First is a three-way partnership. So kind of like David talked about both grassroots and grass tops, they also had kind of an outside in, and I kind of served that role with our school projects. And so the bottom up was basically the folks who wanted to work on child obesity and fitness within our school system. I came in as an outsider, and then our next step was getting the administration to buy in. So another principle this model uses is action based on local data, where essentially people are less likely to believe data from some other state, but what's your own data you're looking at that's a little more powerful. The next slide, next click, there you go. So, and then also trying to figure out the folks you want to change, making this be seen as their best interest. And so how we got top-down buy-in, if you want to go to the next slide here, we started working on obesity and fitness data across the district, which certainly got people like me with a public health bent interested. But we found that when we were able to take our stuff and correlate it with the reading, math, and science scores, that really got buy-in from the administration. And so basically the NISA, the Nebraska Accountability Test that No Child Left Behind used to make us fight over, that scared the heck out of a lot of principals. And so when we could show that our fitness stuff might be improving the reading, math, and science scores, that really got a lot of buy-in. And I think that's we started doing this in about 2012, and that really got us a lot of traction. Go ahead, next slide. Since that model came out, that was when I had in grad school, the collective impact I think is starting to gain a little more credence. It came out in late 2011, but I think it's really percolated a lot. Kind of along those same models before, the common agenda. If you can get everybody to agree to the same project, mutually enforcing activities, shared measurements, which again goes back to the data of the other system. And the other thing they add is the backbone support organization, which is the PICH grant has really allowed us to be, I think, kind of like David's presentation about Boston. Go ahead, next slide. So, our common agenda we put together, we want to improve the health of Lincoln's kids, and it's actually not too hard to get people to buy into that, other than, of course, we had to get the school leadership that was so worried about math and reading to get bought into it. Our measurement source, we actually use the Lincoln Public Schools data, and so my role is to actually help them analyze their data. The school nurses polls do BMI screening in case-rate kids. The PE teachers use the FitnessGram Pacer, which has kind of become the gold standard of fitness in elementary kids and middle school. And then by using that data, we've been able to set targets, which has really helped build the coalition and kind of align everybody. So next slide. So this is kind of our progress. We set a goal by hitting a certain target by 2015, and we did reach that target. And so we've had your increases in fitness and decreases in child obesity. And so we've now set actually 2020 targets. Go ahead, next slide. So we were able to get a 10% reduction in child obesity based on our baseline in 2010. So we're going to try to get 20% from that 2010 baseline by 2020. And we really, as we've gotten more into this, really focusing more on the fitness side of things. We just want to see if we can get all 80% of the kids passing that FitnessGram test in all grades by 2020. Next slide. So essentially, that common agenda and shared measurement system really became the BACS became kind of the aligning force within our organization. PICH grant is what helped fund us to be that backbone organization. Mutually reinforcing, and one of the benefits of the PICH grant is that they require a lot of co-funding and sub-grantees. There's nothing like aligning a lot of folks and having funding pushed out to 13 or more folks. Everybody's getting funded for the effort. It does really help keep people aligned, actually. And then communication, I think, is probably one of the things I've learned the most in the last 6 years that I had some weak areas, is that you can't over-communicate. Next slide. So here's our partners, actually, and so of all those 13 organizations, almost all of them are here. We have people from the community organizations, Hispanic, African American, Asian community, the YMCA, our community gardening organizations, schools, a whole bunch of folks. Go ahead and hit the next slide. During our partner meetings, one of the things we've learned is that, I think, make sure that you're not just lecturing to folks, make sure that everybody gets input. So a lot of our meetings, we start with kind of a round robin where everybody around the table gives a kind of a 1-minute highlight on what they're doing. When you've got 15 folks, that ends up taking up about half a meeting. But there's a lot of surprising aligning activities when people say, well, I'm doing this, and they'll say, well, so are we. They'll start meeting together after the meeting and allow them able to share some resources and efforts, which has been very helpful. Highlighting everyone as part of our communication strategy, that's really helped. We don't push out anything publicly without involving other folks, and when we send a constant contact newsletter out to everybody, we highlight at least 2 other organizations. When we record PSAs and community conversations for our health channel, usually there's 3 to 4 people that are interviewed from different organizations, and so really trying to make sure that everybody gets their little attention through some of this. There's a presentation similar to this a few months ago that the CDC put on, where I think it was San Diego, where they're also working on a memorandum of understanding and a vote on local grant applications. And it was interesting, they came up with this partly to make sure that there weren't any, basically try to minimize external competition or internal competition. Go ahead and switch to the next slide. One of the things we've run into periodically, and some of you may have done this as well, that there's a dark side of community organizing. One is internal competition for funding. Sometimes the funding within a community is somewhat of a fixed pie, and if you get a grant, somebody else doesn't get the grant. And trying to figure out ways around that so that if you're trying to corral a whole bunch of organizations, that you're not seen as a competitor. We've had to dance around that quite a bit. The PICH grant really helped us because it essentially made the pie bigger within our community by bringing in external funding for our projects. Another thing when you're working with community organizations, some folks are very passionate about their nonprofit. It's hard sometimes for some folks to take input. It's kind of like criticizing somebody else's baby, and so you have to be very tactful sometimes in trying to get people to look at things a little different and realize some things might need to change. Turf battles can be an issue. I think some of the best efforts are both public-private partnerships, but some people on the public side aren't so wild about the private, and some people on the private side aren't so wild about the public side. And so trying to figure out how do we maintain that balance. We've had some trouble with bad actors. So, for example, our Pepsi distributor a few years ago, we had some beverage initiatives, which, of course, they're not wild about. They actually went and told some of our partnering organizations they wouldn't receive any event money anymore if they kept working with us. And so that caused a little angst, of course, and so we had to deal with that a little bit. We've had a little struggle getting our city to work with us in the beverage policy part because they have a sole source contract importer ranks for Pepsi, so they're getting money from Pepsi. So the city's a little touchy about working together in beverages. I think some of you may have seen the article in San Antonio where a health commissioner got fired over something like this. So trying to figure out how do you work around the fact that making people healthier isn't always positive for some folks out there. Next slide. And then just recently a new article from Health Affairs that actually pretty much echoes the same other 2 models you mentioned, the 4 enablers of health innovation, where they studied really innovations worldwide, what were the most effective, and these were the 4 things. So the vision and strategies, it's figuring out how you align everybody. I think that shared data and common goals is key to that vision and strategy. Having a designated agency that's in charge to make things happen between the meetings and get stuff done, but also dedicated funding so you don't get stuck competing with each other in funding, and then, of course, communicate. So, all right, next slide, and I think that's it for me.
Okay. Bob, thanks for sharing information about Partnership for Healthy Lincoln. Attendees on today's webinar, now is a great opportunity to to go ahead and post questions if you have questions for any of our speakers. Again, the best practices that were listed at the beginning of the presentation are not comprehensive, but we've seen some very good examples across all three of the communities, including things like starting with those you already have existing relationships with. We've seen examples of how communities have been able to leverage existing resources to pull champions, formalize structures, and also provide training to help build up the skills of those who are part of the coalition. Additionally, we've also seen examples of how communities have selected a lead organization, but have also provided opportunities for equal input from coalition partners. If there are any questions, actually, we do have one question. Let's start with the first question we've got here. This question is for, okay. This first question is for Aaron and Boise. The question is, are you able to share some of the data collection tools with us to use or tweak for our use? Planning on that. And are you planning on sharing the toolkit that was described?
I'm happy to share some of our survey methodology as well as our price analysis tool. And the toolkit is something that is not yet fully developed, but if anyone is interested in receiving a copy of that when we're finished, I'd be more than happy to send it your way, and hopefully it works its way into somebody's hands who does some meaningful work.
Okay. Thank you, Aaron. Okay, our next question is for David in Boston. The question is about the, let's see here. They described a collaboration and participation with Boston Public Health and participation of 2,000 people in 80 community-based organizations. Did you actively pursue those organizations, or did they request to join, and how do you communicate with them?
Well, the health planning process that we went through, we had a number of partners already, and so then we did extra outreach because we did it both in neighborhoods as well as citywide. I'm sorry, I'm hearing an echo. We did it in a variety of ways. We did surveys, we did community groups, we did focus groups, strategy meetings, and so that we got that many people involved. And part of what we were trying to do is create these cross-sector relationships because, as we know, health is lots more than health care, and involving community development corporations and other community-based organizations was a great way to do that. So that was prior to the PICH grant, but we communicate, we also use constant contact, and I agree that there's no such thing as over-communicating. Even though you think you've reached lots of people, there are lots of people who haven't, and so you encourage people to spread the word. And I guess hope that answers your question.
Okay, thanks, David. Let's see, the next question here. Okay, is how involved were the coalitions in the needs assessment process? So let's start with Bob first.
Okay, so part of our PICH grant, basically a lot of the same people around that table for this coalition actually were also part of the community health improvement plan that the city put together. And so basically they put together, kind of their went through BRCS measures, vital records, and basically people prioritized what the major issues were. And the project we work on basically takes some of those measures. So, they kind of create the model or the targets, and then we try to actually implement them in the communities kind of role to serve. So with obesity and fitness, for example, the obesity and fitness targets that are in the community health improvement plan that health department together come from the Lincoln Public Schools data we work with. And then we have other measures like our breastfeeding measures that come from the WIC program. We have colon cancer screening project that we work on. So there's kind of it's a lot of back and forth between organizations and the health department.
Okay, thank you, Bob. How about Aaron in Boise? And the question
Yeah,
is,
so
yep.
What was that?
The question is how the coalitions, how involved were the coalitions in the needs assessment process?
So our coalition, along with our partner organizations, were very involved in the needs assessment process. Since we were collecting a lot of our primary source data, we relied heavily on our partnership with the university and our partnership with ULI to provide us with some of the baseline data that informed our future collection methods, as well as some of the final data as well. Especially with the Urban Land Institute corridor study, they gave us some great transportation data and some great walkability indicators that we wouldn't have had otherwise.
Okay, and David, would you like to address the same question?
Yeah, our coalition was actually led the community health needs assessment process. Now in Boston we have 12 teaching hospitals, all of whom are required to do community health needs assessments also. So we have lots of data. The coalitions that are part of our alliance were involved because what we did is we were able to provide them some resources to do this planning process on the neighborhood level so that we wouldn't lose the neighborhood specific issues that if you just aggregated data citywide would get lost. And then when the PICH grant came along, there was a specific overlap between some of the strategic issues that we had identified and what we could address through PICH.
Okay, thank you. We are getting close to the top of the hour. We do have 2 more questions, so we'll see if we can get through this quickly. The next question is, tying in with existing coalitions was mentioned throughout the webinar. Would it be appropriate to partner with an existing, with an existing health equity zone in our targeted area? Do any of the panelists wish to address this question?
This is David in Boston. I'd be happy to. There's a lot of energy in this city, which was just named the most unequal city in America in terms of income. So those of us in the activist and health communities are very involved in health equity initiatives, both around training but also about moving this forward. The PICH grant itself has some very specific rules about what you can and cannot do. But we, as the Boston Alliance for Community Health, are very involved in health equity issues and alliances, and there's a governing to achieve racial equity movement here in Boston that we are a part of.
Okay, thank you, David. We do have a question.
I guess the other thing I just wanted to add is that I think an advantage to the in our coalition with the health department is there are some things that we can advocate as a not-for-profit that they as a city department just are not able to do, and so we often trade off roles so that we can accomplish things.
David, I think that's a good example of leveraging strengths and differences between partners. Okay, we have time for 1 more question. I'm going to bounce this question to Aaron. The question is, any insight on prioritizing needs of community? On prioritizing needs assessment process is helpful since it feels like we have a limited time frame, a short funding cycle in which to plan and implement actual grant activities. This is especially relevant in rural communities that lack an excess of local data. Aaron, I'm bouncing this question to you because you actually are working on the implementation project, whereas the PICH communities have a 3-year time frame to implement their projects. On the implementation projects, communities have a shorter amount of time to gather momentum to get some of the work done. How did your coalition prioritize the needs assessment data and information for such a short time frame to work in?
I think that's a really great question, and something we as a coalition spent a long time discussing was how do we ensure the sustainability and the actions of our coalition become implementable actions. And one of the things I think is really important to highlight is that from the very beginning we started identifying agencies and actors who could hopefully take our coalition's work to the next level. The Plan for Health grant was just a little bit over a year, so we didn't have much time to both collect the data and start looking at the ways to implement some of our recommendations. And so with our partnership with Energize, the city of Boise, as well as some of the other local agencies like Let's Move, we've been able to take our ideas and put them into the hands of community champions who we're hoping will contact us if they have any questions moving forward, but really will take these on as some of their own initiatives just because the scope of our work was too limited. I don't know if that answers the question entirely, but...
Okay. Thanks, Aaron. Okay, we are out of time for today's webinar. If you have additional questions, contact information for each of the speakers is listed in the PowerPoint for today. We will share a recording of today's presentation as well as slides from today. And we thank all of you for your time this afternoon. Special thanks to each of our 3 featured speakers for sharing information about their coalitions, their successes, their challenges, and some of the best practices that have worked in communities across the country. With that, I'd like to conclude today's webinar. Thank you, everyone.